good afternoon, everyone. Welcome. If you haven't eaten, please help yourself. We've got plenty of food. I'm Herb Aronow, and I'm moderating our lunchtime symposium, Proof to Practice Treating Hypertension with uRDN. I'm the medical director at Henry Ford Health for Heart and Vascular Services in Detroit, Michigan. Got an all-star cast here who will be covering some really interesting topics. Debbie Cohen from University of Pennsylvania, who directs hypertension programs and clinical research in the renal division. Eric Sisemski, who is the director of vascular intervention at the Cardiovascular Institute at BI Deaconess, and who's the section head for interventional cardiology and vascular research as well. Michael Block, who's medical director of vascular care at the Renown Institute for Heart and Vascular Health in Nevada. We've got Jay Geary, also from the University of Pennsylvania, the associate director of the cardiovascular cath labs at University of Pennsylvania Hospital. So we're going to start off with Jay speaking about what is uRDN. We'll move to uRDN clinical evidence by Dr. Block, a case-based discussion from Debbie Cohen, and then we'll finish up with how to go from proof to practice, Eric Sisemski, and hopefully leave a little time at the end for some Q&A. Thanks so much.
Thanks so much, Herb, and to Recor and SCAI for the kind invitation here. What we're going to do is present what we think is going to be a transformative therapy here in the near term. It's been investigational to date, but we're hoping that changes over the course of the next several months to a year. So first, let's talk about what uRDN, which stands for ultrasound-based renal denervation, is. Some disclosures. The only one that's relevant is the bolded one at the bottom related to Recor. So just to take a step back, what is renal denervation? Well, it's potentially a minimally invasive option to treat hypertension. And the idea here is that we're trying to interrupt the sympathetic neural activity between the brain and the kidneys. And we do that by targeting efferent and afferent sympathetics in the periadventitial nerves that surround the kidneys. And the beautiful thing about this is that while this has in the past been studied in the very distant past, 1931 you can see here, 1952, and 1953, with surgical procedures that seem to show proof of principle that surgical sympathectomy could decrease blood pressures. We now are in an era where we're able to maybe target these renal nerves endovascularly. And specifically, you can see kind of how these renal nerves run surrounding these renal arteries. So the idea came up that maybe if we understand where these nerves are, well, they're surrounding the proximal, middle, and potentially distal renal arteries. And we're able to take a concept of actually using ultrasound-based sonication via thermal injury to disrupt those nerves while keeping the vessel itself cool on the inside to avoid intimal injury. We could accomplish kind of what those original proof of principle showed with surgical sympathectomy with a simple endovascular procedure. So that's the conceit behind uRDN, which aims to put a balloon catheter into the vessel and then carry out 360-degree ultrasound sonication to disrupt these periadventitial nerves. And the system that's used here is called the Paradise Ultrasound Renal Denervation System. And as mentioned, there is a balloon that is going to go up and seat itself in the vessel, making contact with the walls of the vessel, most importantly. And then that allows for transmission of ultrasound waves from the sonowave transducer out to the appropriate depth to disrupt the periadventitial nerves. And specifically, all of this is automated, where that generator gives 7-second sonications at a time, based on the size of the balloon, with the appropriate frequency to reach the appropriate places around the renal artery. So this isn't things that you have to worry about dialing up and dialing down. As I mentioned, you're designed to deliver circumferential denervation to ideally target all of those nerves outside of the vessel that I showed you on the prior cases. And then I mentioned the concern about this type of approach is, oh, there's got to be some kind of intimal injury that it could occur, especially concerns about thermal injury. And one of the things that happens with this system is that cooling jets of actually water are going through it the whole time to protect the intima and keep that cool while the areas outside of the intima get very hot to ablate things. And you'll end up seeing how that looks here. As the balloon goes up, There's sonication happening here. And the concept here is that you would do this in usually about 3 different places in the main renal artery. And we'll just see once more in the live video of how the ring of sonication happens. But you notice that the cooling enables the part that's right outside of the balloon, which is, remember, you're in contact at this point with the intima. So the intima and the media, you can see, would be spared from the heated sonication area. So how does this look, and what are the steps to a procedure? Well, this is an example of a case that we performed recently. I'll just show one of the sides, for ease, but you can obviously understand that you would be able to go into both sides and potentially into accessory arteries as well, down to vessels around 4 millimeters in size. So we start with an invasive renal angiogram. This is being performed with an OmniFlush catheter. And usually you're going to place that catheter if you don't have CT before, which we usually do in these cases, but usually place it in the L1, L2 interspace to take your picture. That'll be the typical place where you'll get a good renal angiogram. And you see here that both of them light up beautifully. We did this with digital subtraction angiography. That shows you where you're starting with, and it also enables you to start with some gross, 2D measurements using quantitative vascular access. Quantitative vascular analysis on your bedside, on your tabletop controls, on your fluoroscopy systems. So we're measuring, around 5.5 millimeters here using that modality. But remember, and then we did measure this little accessory renal down below as well. It's obviously going to the lower pole, so there will be some consideration about targeting that as well. We measured the left side when we selectively got into that. Then in this case, we actually did perform IVUS as well, which is actually quite informative. The vessel was a little bit larger than we had thought on our quantitative vascular analysis. Obviously, the IVUS is going to be like a lot more accurate. So a quick run with the IVUS is a very reasonable thing to do in these cases to appropriately size. You're then going to go ahead and get selective angiography here. So in this case, usually that's going to be kind of there's different options, an IM-shaped catheter, a JR-based catheters, and there's some other catheters that can be used. But they're catheters that point their way directly into the renal artery. Take selective angiogram. In this case, what we're keeping on the screen now, we're coned in, so we see the whole kidney on the one side. We're keeping our eye on a wire that's placed now distally. We purposely try not to use hydrophilic wires. We use standard workhorse wires. So your Pro Waters, your run-throughs, your BMW Universals are your typical wires. This is a run-through placed here. The idea here is that one of the potential complications is distal wire perforation. That's more likely if you lose track of your wire and it's hydrophilic. But this is generally very straightforward. Place that wire through there. You're then going to advance your balloon catheter through there. This is the recourse system essentially going through. This is right now, in this generation, through a 7 French guiding catheter. So you have a 7 French vascular access in the groin. There will be iterations down the line that probably get this down to 6 French and maybe even radial approaches. It's probably common sense that everyone here is thinking that those would be natural ways for the field to progress. You then are going to go ahead and blow up your balloon. And the balloon is actually inflated here. It's not radio opaque as it blows up. But because the system tells you it's inflated, you can press that button and it beeps and tells you it's inflated. After it's inflated, the key thing is you want to be absolutely sure that you have contact with the vessel wall. So what you see here is that I've taken a puff, and there's a stagnant column of dye that is not going downstream. And I hope everybody can see that there in the proximal renal artery. It's not filling the entire renal artery because the balloon's blocking it. You want to see that. So you take a puff, make sure that no dye is going around your balloon. That shows that you have contact. Contact's extremely important. Once you have contact, you press a different button that gives the 7-second sonication, and then you're good. You go ahead, and I picked one that was in the middle portion of the vessel, just to show one example. But in this vessel, we would have done this 3 times. We'd go a little distal in the main, proximal, middle, and then proximal. And we'll usually stay about 5 millimeters distal to the ostium of the vessel. And we'll also generally stay 5 millimeters proximal to the bifurcation of the main renal artery. If for some reason you have a short renal artery, 2 sonications could well be fine, and we often frequently find ourselves doing that. At the end, after you've done your 3 sonications, which are about 7-second bursts up and down, where your balloon goes up, you take a puff. Once you're happy, you press the sonication button. You're good. Things to be aware of is the patient will have some pain. Those nerves hurt. But the positive here is they'll feel it usually only for 2 seconds. You always hear them say something at the 5th second of the 7 seconds. It's basically from second 5 to second 7, and then it ends. You do use fairly heavy sedation. But still conscious sedation, just administered by us and nurses, to make sure that they at least don't have memory of that, and that's a little muted because you have these 2-second bursts of a little bit of pain there in the flank area. So the overall concept here is pretty, and then after that, you'll obviously take out your system. You'll target the left side. Accessories, if they're of appropriate size, can be targeted as well. And the balloon sizes come in about 4 to 7 millimeter ranges right now to treat the broad array of vascular anatomy that you might find. The key to make your procedures most efficient is to make sure that you've measured properly and you've used and you're in contact with the vessel wall. If not, you'll find yourself having to exchange and use multiple catheters in a procedure, which is not the end of the world for you, but it makes things slightly less efficient. And this procedure, as you can probably tell, can be extraordinarily efficient. It can be actually very quick to get a case done. We usually finish and use a vascular closure device in the right leg because that gets the patient up and around and potentially even discharged on the same day. And that's really the whole story. So I'll ask if the panel has any single question, but this I think was pretty straightforward.
Jay, that was great. You know what I might do is just say, let's hold off on questions till after the second talk, and then we'll have a little bit of discussion. So I'm going to welcome Michael Block up to the microphone. Michael's going to speak to us about uRDN clinical evidence.
Thank you very much. So it is really exciting to hear so much excitement about renal denervation at this meeting. I know, though, that SCAI is a very data-driven organization. We're all very data-driven. I want to make sure that we're all talking about the same foundation of clinical data that we've accumulated. So I want to take a few moments and go through that data in some detail just so we all have an understanding of what we do have available to us and what may be coming down the line. Here, of course, you see my disclosures. And there have been a number of studies that have been done or are planning to be done with renal denervation. This is ultrasound-based renal denervation. I'm going to be concentrating on the 3 prospectively powered randomized controlled clinical trials that are in the middle of this slide: the SOLO study, the TRIO study, and RADIANCE 2, which was the pivotal study. It is worth knowing, however, there's also a prospective randomized controlled trial that's being done in Japan. That's at the bottom of the blue section there. That's the DUO study. And we do have a continued access protocol, so we're still denervating patients and collecting data on those patients in FDA-mandated access protocol currently. There's also a patient preference study that's ongoing. There is plans for a registry once this is being used commercially throughout the world, and there's some plans to potentially look at other future indications in the future. So going back to those main 3 studies, SOLO, TRIO, and the pivotal study, they all share a lot of methodology in common. SOLO and RADIANCE 2, the pivotal study RADIANCE 2, were done in patients who'd been washed out of all medications. TRIO, the one there in the middle, was in patients who truly had resistant hypertension, taken off whatever medications they were on and put on a fixed dose triple pill combination ACD therapy, as we discuss. So in SOLO and RADIANCE 2, as I said, patients were washed out, and then to be in the study, they had to have a blood pressure, a daytime ambulatory greater than 135/85. Patients in TRIO had to have a daytime ambulatory of over 135/85 on that triple pill combination. Turns out that triple pill combination, we had a pretty high screen failure rate because that is pretty good therapy and did control a lot of patients. Once we made sure patients satisfied those ambulatory blood pressure criteria, they underwent blood testing, CTA, to make sure they had appropriate renal anatomy, and then they were randomized to either renal denervation or to a sham procedure. It was 1-to-1 for SOLO and TRIO. In RADIANCE 2, it was 2-to-1. 2 patients got active therapy for every 1 with sham. You see the few key exclusion criteria on the bottom left of this slide. We didn't include anybody under 18 or over the age of 75. No recent cardiovascular events, no type 1 diabetes or poorly controlled type 2 diabetes. And importantly, the GFR had to be above 40 for all of these clinical trials. The patients were kept on that baseline therapy for 2 months after either sham or the renal denervation procedure. And at 2 months was the primary outcome assessment. So that primary outcome was change in daytime ambulatory blood pressure between the actively treated group and the sham group. After 2 months, in all of these studies, patients had medicine added back to them. So some of the longer-term data that we have shows a durable effect even once medications are added back. So here you see the results of these clinical trials. This is the primary endpoint. Once again, daytime systolic blood pressure, renal denervation as compared to sham. The two studies on no medications, these are really proof of concept studies. Does renal denervation lower blood pressure in the absence of the confounding issues that are associated with background medicine? Answer is yes. 8.5 millimeters in solo, 7.9 millimeters in Radiance 2 as compared to baseline. You see there was, as compared to placebo, 6.3 millimeter reduction in daytime. In TRIO, remember these are patients who are on a background of 3 medications, truly resistant hypertension. Once again, statistically significant reduction in blood pressure, 8 millimeters in daytime ambulatory systolic from baseline, a difference of about 4.5 millimeters between renal denervation and sham. So ambulatory is very, very important, but it wasn't all that we looked at. We also looked at home and office blood pressure. What I'm showing you here is pooled data because these studies each shared a lot of methodological similarities. We were able to pool the data across those 3 studies and look at the results in aggregate. And what you see on the left side is that primary endpoint again, daytime ambulatory systolic, reduced 8.5 millimeters from baseline. What you see in the middle is home systolic. Once again, this is at 2 months. And on the right is office systolic. You see the results there, looking at about 8 millimeters from baseline in terms of home, about 10 millimeters from baseline in terms of office. And you see the placebo-controlled differences there as well, all of which were statistically significant. We did look at responder rates. There's lots of different ways you can define a responder. We looked at 2 different cut points, a greater than 5 millimeter reduction of blood pressure and or control, or greater than 10 millimeters of blood pressure reduction and or control. And what you see, if you look at 5 millimeters, which was the primary analysis that we looked at, about 2/3 of patients controlled. Either their blood pressure went down 5 millimeters or they were less than 140 over 90. That's on daytime ambulatory blood pressure monitoring. In terms of subgroup analysis, this is once again from the pooled analysis. So very consistent effects in all of the subgroups that were looked at. This is both a good thing and a bad thing. It's a good thing because we have a real consistency of effect in all of these patients. Of course, it would have been nice, though, if perhaps we had found a predictor of response whereby one group of patients may have responded better than another, and we could have potentially been targeting those patients once we got to commercialization. Doesn't seem to be the case. All the subgroups that we looked at seem to respond to renal denervation as compared to sham. Efficacy is important, but safety is important as well. This is once again pooled data looking, this is 30-day, there's also 6 months data that's been published. And really besides the few minor access site complications, we really haven't seen to date any major safety concerns. No change in renal function, no real significant increase in the incidence of renal artery stenosis, no significant increase in the risk of cardiovascular events. Durability is very important in this field. In order, once again, to decrease the confounding issues of background medication, we found when designing these studies, I say we because I was on the steering committee of these studies, we found that it was important to keep that primary outcome ascertainment window narrow, to have a short ascertainment window so that patients could remain off medicines or on the appropriate background medication. But durability is important, and so we have followed these patients out for months and, in fact, years. And so we have some of the data that we've collected. The solo patients we've been following for the longest, and as you can see, they have, this is when medicines are added as well. In solo, we have a durable difference of 17 millimeters reduction in blood pressure. This is actually office blood pressure from baseline out at 3 years. Interestingly, patients are on essentially the same number of medications that they were on when they were screened for the study. So it's essentially the same number of medicines, but with this, a decrease in blood pressure. We have 6-month data from TRIO shown on this slide. We hope to be publishing the 24-month data shortly. And then there's another study, ACHIEVE, which is a single-center study that also, single-arm study that also showed some significant durability of effect. So over the course of this development of this data, we've had numerous different papers, position papers, consensus documents that have been published, including a real flurry of them in the last couple of years. I'll call your attention to two of them. One was the SCAI NKF document that we published I was on that panel that we published in 2021, and then the ESC document that came out just a couple of months ago. One of the things that we spent quite a bit of time thinking about in the SCAI document, and also the Europeans did for their document, is who might be an appropriate patient for us to consider for renal denervation. And we're going to give you a couple patient cases here in a moment, but I just sort of wanted to begin to get you to think about who might be an appropriate patient for renal denervation. This is from the SCAI NKF document. We highlighted patients who had persistent uncontrolled high blood pressure despite the prescription of guideline-based therapies. That is, patients who are treated but not controlled. Not just a resistant population, but patients who've been treated and on whatever therapy they're on, they're not controlled. We think it's important, or we thought it was important, that poor control be confirmed out of the office, exclude secondary cause. I think to get more value from the procedure, I think it's important that we be essentially at first limiting this target population to patients that are at higher cardiovascular risk. That may be because of their blood pressure. It may be because of other cardiovascular risk factors. And then, of course, we want to do this with shared decision-making, make that decision with really an involved and activated patient who prefers therapy, this type of therapy, over increasing or intensifying their pharmacologic therapy. The ESC, when they came out with their guidelines in 2023, I think really boiled this down to a couple of key points. They think that this is an appropriate therapy for patients with uncontrolled resistant hypertension. That is office readings greater than 140/90 that are then confirmed out of the office by ABPM. They really think it's kind of I wouldn't say a slam dunk, but something that should definitely be considered in these patients with uncontrolled resistant hypertension, GFR greater than 40. But they also say that it may be an option in patients who don't meet the criteria for resistant hypertension. High-risk patients who are unable or unwilling to take more medicine could also be considered for the procedure. And importantly, we should be looking at risk as well as blood pressure when we start thinking about who to choose. So as we look through these cases, I just want to, I'll leave this slide up just as a conclusion. You know, I think it's important that we think about renal denervation as part of an armamentarium, part of a toolbox we have for patients with uncontrolled high blood pressure. And really the key question when you have patients who come in is, would that patient rather intensify their medication regimen, or would they rather consider renal denervation? Doing nothing is just not an option. We now have, I think, really good data across this spectrum. Patients who are on no medicines, patients who are on 1 to 2 medicines, patients who are on 3 to 4 medicines, that renal denervation may have a role in patients who would prefer that over intensifying their pharmacologic regimen. And I know Eric is going to drill down into the things at the bottom of this slide a little bit more in just a moment. But with that, I think I'll conclude. And I don't know if we're going to do a discussion now.
We were, Michael, but I think I'm going to push the discussion to the end, and we'll just keep going. Debbie, if you want to come up for the case-based discussion, I think that would be great. Just want to make sure we have time at the end for questions and for some panel discussion. So thank you.
Okay, so I'm going to present 2 cases, and I'm going to expect the panel to be very interactive. And if the audience has any suggestions, please feel free to chime in. So the first case is a 66-year-old African-American male with a history of hypertension for more than 12 years who comes for routine follow-up for his hypertension care. He's feeling well. Home blood pressure that he brings in averaged over 5 days is 158/84. Other relevant history includes it's already been worked up in the past for causes of secondary hypertension, including primary aldosteronism, pheochromocytoma, and renovascular disease. He's had type 2 diabetes for 10 years, significant coronary artery disease with an end-STEMI and angioplasty in the past, and ejection fraction of 55%, chronic kidney disease with a GFR of 46, prior smoker for 21-year PAC history, but quit 20 years ago, and family history of hypertension. So these are the medications he's taking currently. olmesartan HCTZ in max doses 40-25, metoprolol succinate 100 daily, amlodipine 5 milligrams daily because cannot tolerate a higher dose due to edema, and then statin and metformin and aspirin. So on exam, I'll just point out a couple things. Office blood pressure is similar to home pressure, 152/87, heart rate of 62. He'd gained a lot of weight. His BMI was 32. And rest of exam is essentially normal, no epigastric bruit, and he did have an S4 present. No pedal edema. Normal electrolytes with a potassium of 4.5, GFR of 46, some microalbuminuria. EKG showed normal sinus rhythm with LVH and non-specific STT changes. And his home monitoring is similar. So let's get to the questions. So I think anybody could just chime in here, guys. So do you think that any additional diagnostic testing should be done?
Michael, you want to tackle that one?
Sure. So it sounds like he's already had a considerable workup for secondary cause. I mean, if he hadn't, obviously, I think that would be important. Rule out primary aldosteronism, make sure he doesn't have a FEO, make sure his thyroid's okay, and he doesn't have raging sleep apnea that could be treated. Otherwise, it sounds like you've done a very thorough job in his diagnostic testing. We've identified him as probably the highest risk person that's going to walk into your office today, right? This guy's at incredibly high risk, and much of that risk is driven by his uncontrolled high blood pressure. So, the first question, of course, is he really taking all 4 of those medications? It's a pretty potent combination, that's something definitely to look into a little bit. As we've added medicines, does his blood pressure come down at all, or is there a chance that he's not taking them? If he is, then I think it's important. It's about time to start having that conversation of, are we going to intensify your medical regimen, or are we going to consider something else?
So right now it looks like he's on 4 drug hypertension with the kind of typical A, B, C, D therapy. It looks like there's ARB, beta blocker, calcium channel blocker, diuretic. So I've learned from Debbie over the years, but Michael yesterday as well, that the next drug in the armamentarium may well be an aldosterone antagonist.
So that was my next question. What, should we make any medication changes? So I think obviously fourth, in this case, 5th line therapy, it would be appropriate to add a mineralocorticoid. He does have CKD though, but his potassium was 4.5. So I think that, would be a good drug to add. Anything else you guys think about adding? He's also diabetic and.
I personally don't use a lot of metoprolol for hypertension.
Right.
So I usually use something like labetalol or carvedilol at this point, but I don't know what else you would add at this point. I think, honestly, I don't know how much more this person can tolerate with this burden of a regimen. That would be my other concern is, and you've shown this slide that 2 to 3 meds, we know compliance jumps, 5 meds, more than 50% are not compliant. So.
Right. The one thing I was thinking is, besides an mineralocorticoid, is obviously, we now have the SGLT2 inhibitors and we have the GLP-1 drugs, and, his BMI is elevated. So that is something to consider, And he is diabetic, so those things are all reasonable additions. Okay, so assuming that renal denervation does receive FDA approval, when should this person be referred for it, and be interested in your different opinions?
Yeah, I think he's on 4 drugs currently. I think he fits, sort of what we've said at SCAI, what we've said at ESC. If that is his preference, I think that's the question, right? So we have a couple of options for him. He could try some spironolactone. We have to watch his electrolytes carefully. A peripheral alpha blocker, perhaps, maybe another pharmacologic option. SGLT2, I think, is a great idea. But I think that I think you have enough to consider renal denervation if it were available to him at this point, personally.
He's certainly a patient who meets what has been studied in the resistant hypertension trials. I think we agree with that. So from that standpoint, we have shown safety and efficacy in exactly this patient population with sham-controlled studies.
Did you have something? Or? You okay if I
I'm
jump
happy
in?
to be skipped, yeah.
So I would say, just to play devil's advocate, I guess I would say it certainly meets criteria, but I think you said, has had this blood pressure for about 5 years, right?
Right.
So you have a little bit of time to play around, right? So, is it worth thinking about adjusting pharmacotherapy and seeing him back in a short period of time? See if you met the target, or do you think it's reasonable to just move forward at this point?
It's a really good question, and we were talking about this earlier. Because of how the trials work, you can't adjust beds. You have to go and get treated, and then you have this blanking period. But in reality, I feel like these things should be happening in parallel, and so having the conversation and starting the process of whether renal denervation is appropriate in the future happens with further medical titration. The likelihood that we're going to get this patient really under good control with good adherence seems very unlikely at this point. And we also talked about his cardiovascular risk being as high as it comes due to his prior cardiovascular event.
That would be one of my concerns too, with adding a fourth or maybe a fifth when it comes down to it, medication, is maybe he comes back in 2 months and his blood pressure is under improved control because he's happened to be taking his medicines. You did such a great job of eloquently explaining his cardiovascular risk when he came in, that he took it for 2 months. But then what happens 2 months after that or 6 months after that, when he may decide not to even come back to see you anymore? He's following up with his primary. So I do think that there's, the adherence independent aspect of renal denervation is something that could be considered here, particularly, and I think really it's about talking to the patient and, what direction does he think we need to go? Does he want to take more medicine? Is this something he would consider? I think patient preference is going to be such an important part of this moving forward.
So, I think I would personally add a mineralocorticoid and give him that chance. I don't think changing the type of beta blocker is going to really make much change to the blood pressure, but I do think this is the time to have a conversation about renal denervation. And, if it's something that the patient is open to, as you say, you could move forward in parallel, because even if he does have a good response, he's still going to be on multiple meds. So there's, we could improve his overall amount of medication or medication burden.
I like that approach. You plant the seed about the potential for a procedure, you make a change, you see the patient back in a month, and if you're still not controlled, then if the patient's on board, then you move forward.
Okay,
Real quick, talking about that, you had a comment there about predictors. We don't have a lot of them.
Right,
One of them has
that's
been, sympathetic overdrive or lack of parasympathetic activity, and that has been a marker of a higher resting heart rate. So have you ever, has that been useful for you, Debbie, at all? Like, we have him on a beta blocker, so we can't really evaluate that right now, but he's on a full dose of Topral with a heart rate in the 60s, so you imagine his resting heart rate is probably higher outside of that.
Theoretically, we all assume that people who have sympathetic hyperactivity are going to respond better than people who don't. But at least, I've seen probably like over 80, 100 people in these trials. And, I can't say that I could predict who's going to respond well. And that's the biggest, the next hurdle, I think. So I've got another case we can look at quickly. This is a 52-year-old white male with history of hypertension referred from the PCP for uncontrolled blood pressure. He's had multiple ER visits and hospitalizations for hypertensive urgency. And he's got it's noted in his hospital records that he's had chronic non-adherence to medication. He's had the full workup for secondary hypertension. He is obese with a BMI of 35 and prior smoker. And family history of CAD, heart failure, and hypertension. His current meds are labetalol 300 milligrams BID, hydrochlorothiazide 25 daily, lisinopril 40 daily, Norvasc 5 daily, and he has been tried on spironolactone and is intolerant. Physical exam, just the important pertinent facts here are the blood pressure 162/101, also S4 present, no epigastric bruit, no edema, normal kidney function, normal electrolytes, and no microalbuminuria. He does have LVH on his EKG, and we do an ambulatory blood pressure monitor, and the blood pressure daytime is 152/92, so there's no white coat hypertension. Okay, so we kind of sort of alluded to this already, but how should the potential non-adherence to his antihypertensive medication be evaluated in this patient? Like, what do you suggest? How do we go about that?
Obviously, asking him, talking to the pharmacy, all those things are going to be important, but he's already kind of proven and said that he's not adherent, and you wouldn't be surprised, right? He's supposed to be taking 5 antihypertensive tablets a day. We know that most people who are prescribed 5 pills a day just for their hypertension aren't going to take all of them every day. And its adherence is not black and white, it's gray. Maybe he takes 2 some day, maybe he takes 5 some day, maybe he takes 7 some days. So I think that rather than spend so much time in the past, and I see tons and tons of these patients, you look to the future. I mean, the labetalol is probably not doing very much for his blood pressure. He could be on a 2 or even 3 drug single pill combination,
Right.
and change his adherence dramatically. So you could put him on olmesartan HCT or even olmesartan HCT with the amlodipine in it. It might be a little more expensive. And then see, if we can get you to fewer pills, will you take them every day? And I really spend a lot of time with these folks looking to the future rather than talking so much about the past.
So, I mean, this is not my real patient, but I would obviously switch them to triple combination therapy straight away, and also I would use like a beta blocker that's once a day instead of twice a day to try and, make it as simple as possible for the patient. But again, here, I think this is something we could think about looking in a parallel approach. But the question is, assuming that when would you consider the patient for renal denervation? Would you do it like right now? Assuming he's fully adherent, non-adherent, or partially adherent, doesn't matter? Like, what do you guys think?
Yeah, I mean, it's obviously, I'll probably take the slightly controversial approach here that I'm not sure I understand why adherence has to be such a big part of this discussion when it comes to this procedure. I think adherence is super important for the management of the patient overall, and having that educational process to be adherent so that they improve their overall outcomes is obviously massively important. When it comes to the procedure and its efficacy and safety, you now have studies that have shown proof of principle in patients who are on newly diagnosed hypertensives or on one-drug hypertension. So we know we're not unsafe, that we're somehow, if he's not adherent and we do the procedure, you don't end up with some like horrible, orthostatic hypotension or something like that. That doesn't seem like it's happening. So this seems like it's something that's just going to help the patient. And I think the key, where the rubber hits the road, is first of all his opinion on procedures, because it is ultimately his choice. And secondly, it will be a little bit of debate from a payer standpoint of what they're going to require before the procedure is available to a patient. But that may be a little controversial, not having to check the boxes around adherence, but I'd love to hear Herb have a different opinion.
Yeah, no, I don't know that I do. I think you're right. We have no reason to doubt the efficacy of the procedure based on adherence, but I just want to sort of build on your point around adherence. I think we have to be careful. I think this is a slippery slope. There are a lot of really good reasons why people don't take their prescribed pharmacotherapy, lifestyle, access, other things. And so I don't think we want to stand in the way of achieving hypertension or blood pressure control in patients because we're assuming this is just sort of it's a willful decision and then they could do otherwise.
So just chime in with one quick comment. So I take 1 pill a day, and it's a 20 of atorvastatin that I've been on for about 15 years. And so I know, I have these 90 prescriptions, so I know exactly when the pills are supposed to be gone. And so I've measured my own adherence. And it turns out it's in the low 80s to mid 80s. And I'm like, who's not going to be, I'm sitting right there next to my toothbrush. I know I take it every morning, and somehow these pills are left, and it's always around the same amount of pills at the end of 90 days. It's about 12 pills, 15 pills are left. And I'm like, what do I got to do here? Like, I don't understand why I'm missing them. I'm certainly motivated. I'm certainly there, but I'm not adherent completely.
Well, I mean,
I believe in stenting.
I feel like one of the things is like an ethics thing, and that's kind of the next question. Is renal denervation reasonable if patients don't want to take their meds? And I think we've proven that it works for sure, whether you're on any meds, multiple meds, etc. But that's why I think this adherence thing keeps coming up. I mean, is it okay to say to a patient, don't take your meds, we'll just denervate you? And I think that's, maybe that's the issue.
Yeah, I don't love that
concept.
Yeah, I don't love discouraging medication taking. But.
So, Eric, any comment?
Yeah, I mean, I think, again, Jay made a comment about payers, and this is where it will be an important part. I think patient preference is important, and we have a lot of patients, we talked about this a little bit yesterday, that come in and have 20 allergies to medications, which are not true allergies as we would define them, but either no one knows why they had a symptom or they just felt like it didn't work for their body. And so there's a gray area here where at the end of the day, the goal is get the patient's blood pressure under control so we don't have a cardiovascular or other event in the near future. And if this is the pathway to do it, I'm not opposed to it. Again, I think, Jay, to your comment, I would never say if you are willing to take meds, don't take them, you know. And I would never tell someone that this is a way to get off meds also. I don't think we're going to get there to start. But I think that we need to respect people's preferences and also their belief about how their body responds to therapy. And we see this a lot, admittedly.
And then the last issue is if the patient was actually fully adherent, how do you manage their medications after the renal denervation? So, and we do have experience from the study, so I don't know. Michael, maybe you
Sure.
want to comment?
I guess the for better or for worse, the magnitude of blood pressure drop, doesn't usually require this sort of, really close follow-up with patients that they're going to become relatively hypotensive. I mean, and this, kind of goes back to that last conversation. For this patient, this is not a substitute. Given the magnitude of blood pressure effect, this is not a substitute for medication. So he needs to know if he has this, it's going to be in addition to a certain number of medicines he's going to need to take. So yeah, I would probably try to just establish that before I denervated him. This is your background medicines, whether it's a 2 or 3 drug triple combination, and then let's see what you look like afterwards. But not setting, I think we don't want to set ourselves up for failure. I mean, I think the anticipation is, he'll be on 2 or 3 meds, plus be denervated. And, when I've had in the clinical trial experience patients who come in and ask me, do you think I'll be able to, do you think I'll have to go back on medicines, or do you think I'll be able to stop any of these medicines? And my answer is no. We're doing this rather than escalating your medicines, right? It's not that we are at a point where we're doing it to de-escalate people's medication at this point.
But I think it's a win, though, because if the patient actually has a goal blood pressure with the denervation and the meds, we've done a good job.
No question, no question.
Okay, any other comments? Okay, we can move on.
Great, Debbie, thank you. I'm going to have our last speaker come on up to the microphone, Eric Sasemski. He's going to speak to us about how to go from proof to practice.
Great, thank you very much. So I think this is a great way to end the session because, again, we've had similar symposiums the last couple of years and trying to paint a little bit of the landscape of how this might fit into our practices, but we're probably closer than ever now. And I made this comment yesterday that this is probably our last SCAI where we're talking about a pre-approval device. And so I'm going to talk a little bit about how we had a vision for this at our center and how we built this out. And hopefully there's some pearls here to take home for everyone who's interested in growing a hypertension program, which I think personally is essential to introduce this technology into your hospital system. So, I think that these are 4 pearls, and a lot of this comes out of our SCAI document that we put together a couple years ago, and you'll see also many of these in the upcoming SCAI document that will be out in the near future and is now public for comment. But I think the idea here is many of us in the room are proceduralists who don't have the opportunity to spend a ton of time in clinic adjusting medications. And so there's really no pathway to success if you're doing this by yourself. And so I think the first thing that we did at our institution several years ago when this was kind of re-entering the landscape of future practice was how do we build a team around this that can support this technology, can support our patients, bring more people into our healthcare system, and potentially as we move forward in the future, support other technologies and other advances in this field. And so we stepped back and we created a mindset that we needed to have a team-based approach. We needed to do exactly what Debbie does. And we needed to really put together a cohesive program that allowed a pathway for patients to enter our system, create a separate track for patients to potentially go in for an interventional-based program, and then come back into our general program. And I'll spend a few minutes going into that more intimately. But I think the other thing was building the awareness among administrators and our centers that hypertension should be a bigger goal for us in terms of mandates for achieving goal target therapy. We did this for statins for a long time, that we would audit our whole system to see if people were on a statin, if they had any risk factors that qualified for it. And then it fell off the table a little bit. And so I think that hypertension is a great benchmark and really important for global management of our patients and healthcare systems. So the slide here kind of demonstrates how we've talked to our referrers and that pathways. And, again, we've worked a little bit trying to catch up from past grievances because we know that the old studies really shut down programs, and many people stopped thinking about this after Hypertension 3. And so, I think making the awareness part of this is probably one of the more important aspects, is to reminding a lot of our referring. And I gave nephrology grand rounds not too long ago, and they had no idea that we had all these sham-controlled randomized trials have come out since that Needham paper from 7 years ago. And so, it's really interesting for us, who I've been following this data intimately for years now, for people to be completely unaware of it. And so I think that reminding us where we are in terms of the new clinical data, ReCore now being on the scene with a newer device, really is an important part of this to change people's mindset about, oh, I remember that thing and it failed and it's gone. I think that the value proposition, which I'll speak about in a moment, is really important as well, because we all have patients who get referred to us, in particular in cardiology, where they think we're going to solve our primary care doctors' hypertension patient problems, and they come and there isn't a lot of options, and they have really advanced CKD. I still do renal artery stenting, and sometimes it works and sometimes it doesn't work, but we don't have a lot of options, and they have enough narrowing to suggest we try it and we do it. And so, now we have a proven therapy that's been tested as scientifically as possible against a sham arm. And so I try to really put that into perspective. And then, I think that as we get that referral pathway moving, the biggest thing that I've seen in our practice is really the feedback system. And we've talked a lot about that. And so we try to call every provider after the procedure. We try to call every provider after they see in our clinic. We have an agreement with our referrers about what our role is. And I'll speak to that again in a few slides here about, are we taking over care? Are we working in parallel together to care for these patients? So, I like this slide because it really brings together for the patient how to think about what this looks like compared to medical therapy in addition to escalating medical therapy. And, I think Michael Block yesterday in our session gave us some nice data on what does a single monotherapy agent look like, which is very similar to max dose to what renal denervation looks like, around 10 millimeters of mercury. And so from an efficacy standpoint, we can make the case that they're roughly equivalent. I would argue that we probably have more data for renal denervation for a lot of the agents we use, but I think that would be a fair comment. In terms of tolerability, I think we all agree that outside of a little upfront cost of undergoing a procedure, you're going to have a much lower risk of an adverse event with renal denervation than potentially, as we age and our bodies change, we can have with antihypertensives. Safety, again, we've seen through Jay's presentation earlier about how these tables are so boring because they're all zeros. We really haven't seen any safety data that have emerged in the 2 months, 6 months, and now up to 3 years for either any of the RDN devices that are being evaluated. We know that adherence favors renal denervation, durability. We've seen data now up 3+ years demonstrating the durability of this effect. Cost, we'll get into as we understand what this will look like with reimbursement, and patient preference is going to vary. So I think that, again, you see here demonstrated in several of these lines that there's a value proposition for a patient. And I always tell the patient, you have a therapy that's always on, that can last up to 3 years, that's safe, and it doesn't require you necessarily to be active in terms of it working. And I think that resonates with a lot of patients. So what does it look like for us at our center at Beth Israel Deaconess? So we had a hypertension center that started in 2016 by my colleague Jennifer Cluett. She's an internist, and she went and started this program and wanted to get AHA certification. And the first thing that happened was creating an infrastructure, again, that was a team-based approach. So we have physicians, pharmacists, nurses, and administrative support to help generate really a pathway for our patients to come into our center and be referred elsewhere. I think that from the clinical care standpoint, everybody will tell you when you run a hypertension program, probably your most important member is your pharmacist, who does a lot of the work in between your occasional visit as an MD or maybe your mid-level who might see the patient for other reasons. And then teaming with specialists. I would not say, we were talking about this earlier, that I would refer my patient for aldosterone testing with endocrinology. We do the testing if we need help with interpreting, or if it's abnormal, we involve our endocrinologist in that decision-making and what the next steps look like. But sending people on a journey to different specialists slows down the pathway and creates areas for fragmentation. And so we try to keep the preliminary testing all within our program, and we have specialists in all the different areas to then follow up, where if we do need more additional help, we can draw on them. So, we've brought a lot of people into our system from this program. Again, this is before really even getting back into the renal denervation system. We started getting much more new consults. This was before Beth Israel, which is now expanded and combined with other medical centers, was really an independent system. We had a very active ambulatory blood pressure monitoring program, and then our pharmacy team really led the way in terms of medication titration. And I think that also this helped us from a global standpoint in our healthcare system of creating goals and strategies both for obtaining optimal blood pressure therapy, as well as additional other abilities to bring patients into our healthcare system for other reasons, whether it's cardiovascular care or elsewise. So now fast forward. So now last year, we're now in the footsteps, the doorsteps of the approval of renal denervation. And we started to build in this idea that we need to tailor therapy a little bit more, and the discussion around how we're going to introduce renal denervation. And right now we're in some clinical trials, and then when this is approved. And again, so we went to our whole network to start advertising this, primarily within Boston area systems. And we looked for outside referrals. We have a lot of self-referral pathways, and we know that a lot of clinical trials have been driven by self-referrals, and then also internal referrals that we've identified through our EHR system. And we kind of have these overlapping Venn diagram here. Right? We have this main hypertension center that is overlapped in personnel, but just a different location with our cardiovascular hypertension center, which we call that complex hypertension center. And this is really the pathway for us to renal denervation. So a lot of the primary screening and evaluation occurs in the primary hypertension center, and then that referral pathway moves into our clinic, where we're now evaluating for an interventional therapy and doing all the diligence in terms of making sure the anatomy is correct, understanding the risks of part of the procedure, and then the follow-up period after treatment. And again, that's really what falls under what I run, which is our vascular medicine and interventional section. And so I think that this has worked really well for us because, again, an internist is not as familiar with referring to a procedure than a cardiologist or specialist. So my cardiology colleagues were the first people to start sending loads of patients. Everybody that came in they thought was a great candidate, and we, some that were, some that weren't. But our primary care doctors are much more hesitant to go straight to a procedure. And so we thought this was a nice pathway to bridge that conversation and bring our own perspective as proceduralists about what we observe as risks. And then also for, again, everybody in the room who is a proceduralist, I can't do this with everything else I'm doing. So I need to lean on someone that if this is going to be successful, someone's checking, make sure there's no procedural complications afterwards. There is maybe not a routine opportunity to decrease meds, but there will be an opportunity in some patients to decrease meds, and making sure that we have tracked our outcomes to feed back to our referring providers. So, I think that we've talked about this a lot yesterday and today, and I think, again, my hope for this therapy is that we are evaluating patients and selecting the correct patients, in particular when this becomes approved, because how we approach this as a community to start will really dictate its success. If we're doing things really without diligence to start or recklessly, we're not going to see this sustainable. And so I think making sure that we know who has resistant hypertension, who has been trialed in medications, and doing a really good job of optimizing our testing beforehand is critical for moving forward into the evidence pathway towards renal denervation. In terms of the preferred candidates, and I think Michael gave a little slide on this also, I think our program has really been starting with the resistant hypertension population. Again, we have a lot of patients coming from nephrology in particular. We look at the risk of the patients as well, including those who have cardiovascular disorders already, chronic kidney disease, and other issues. Non-adherence, we just spoke about a little bit, and I think this is an area we're going to probably move into, but we're really thinking about the non-adherent who really needs this therapy, not the non-adherent who is on one agent and wants to be off the agent to start. And again, I spoke a little bit about intolerance to antihypertensive medications. Before I end, I just want to make sure this is, to me, one of the most important things in terms of how we create this pathway is outside of what's in the light gray, which is confirming eligibility, the more important thing is the post-procedure and patient follow-up. And again, we are tracking our data post-procedure to make sure that we can send that back to our providers and our referring people. We could put this in the medical records, and we could give it to the patient so that they can observe also what the benefit of this therapy has provided. And I think this is what's going to create a cycle of referrals to sustain this program. And so I'd really, when everybody steps out of this room today, think about what resources are available at your institution. Think about some champions that can play a role. And also think about who are going to be your main referring bodies, because I think that the relationship with them, as we all know, as proceduralists in particular, sustains our growth. So I'm going to stop here, and we'll have time for questions. But thank you very much.
Eric, thank you. That was great. So we don't have a lot of time left. We've got about a minute, actually. But if there are questions from the audience, please, there are 2 mics. If you want to come on up, we'd welcome the chance to address those. I think while we're waiting, well, actually, you're there, so please, go ahead.
All right, so thanks, guys, so much. Really interesting talk. I learned a great deal. I'd just be curious from the panel's experience. In the last couple of years, I can think of a couple of patients who are well controlled with their blood pressure at baseline, but then when they put them on a treadmill or exercise, the pressure's shooting up and they're getting short of breath. Is this a potential therapy for those patients? Because I'm looking at them, I'll say, your blood pressure is 120 over 75 in the office on 1 or 2 meds, but 4 minutes on a Bruce, you're 220 over 120. So I was thinking this is a potential therapy for that, but I would be curious what your thoughts are, what your experience has been with either exercise-induced hypertension or periodic hypertension, which you think is probably catecholamine driven.
Debbie, you want to tackle that?
Yeah.
Well, I think there is data actually in exercise-induced hypertension that it's often just intermittent and it doesn't have long-term effects. But I mean, if I was you, I would do an ambulatory blood pressure monitor on that kind of patient, because maybe they've masked hypertension and you should be more aggressive, and they probably would do well with the renal denervation.
It is. It's a patient population that people have suggested need to be studied. Hasn't been studied yet, though, right? So far, we've looked at patients with sustained, poorly controlled high blood pressure. So I think we need to figure out what we're doing with that patient population. But I think it is one that people are very, very interested in, and as well as others, patients with pseudophagocytoma syndrome and other syndromes that appear to be sympathetically mediated. But we just don't have the data.
Great. One more question.
Yeah, thanks, Dave Zeider, Cleveland case. So super interesting topic, and thanks everyone on the panel for their input. Very interested in the short discussion on compliance when we were enrolling for Radiance. Certainly we know that we help patients that we do the procedures on, but oftentimes I really felt as though when we walked in the room and sort of discussed a procedure, there was a segment in whose patient compliance immediately became super optimal. And those patients were forever grateful that they were at least sort of introduced to us Grim Reapers. So I think regardless, the message is we should be active. There should be programs evolving. Finding champions in a multidisciplinary setting is totally crucial. And sometimes, our role will be unseen, but felt and heard. So thanks.
And I love that topic. And again, I think for us, like I have a junior faculty member who's running our program. And the nice thing about this therapy also is bringing in patients who might be interested in it and may not be great candidates, but are now part of our program. And so there's 2 sides to that as well. And I think that the draw is great. And also it's great to scare people into compliance. So.
So I know we're short on time. I'd just ask one question to the panel. And Eric, you sort of wrap things up talking about how we operationalize all this, right? What does the hypertension center look like? And, it got me thinking a little bit about how we best find those patients, right? Is it active? Is it passive? Do you just build it and they come, or should we be targeting them? And I think you alluded to targeting patients, and maybe you could speak to, or others could speak to, opportunities through social media, because we know that's been effective for clinical trials. And then you mentioned the EMR or EHR, and sure, people can refer you patients, but is it more than that? Can we dig a little bit deeper beneath the surface and maybe query and find all those patients who we know aren't at goal and try to help them get there?
Yeah, great questions. I think a few points. I was talking to someone who works at the Veterans Hospital in Chicago, and he said he looked in there. They have a very comprehensive EHR. If you've worked in the VA, he said they had 4,000 patients on 3+ meds for hypertension, and then he was able to fragment out how many were poorly controlled in the last visit. So I think those type of data are really helpful, and at least can create a system to flag for the provider when they see that patient again to consider referring for a hypertension program. And we've done this for other conditions, including for our structural heart team. I think the referrals for our own institution have come from many sources, and we haven't really gone to social media, which I don't think we're ready for yet. But again, we've given a lot of talks within our other partnering groups like nephrology, endocrinology, and then advertised to our sister hospitals in the community. And so, I think it's a comprehensive approach, but I think just like we've done this before for structural, for me, for peripheral and PE, this is kind of what we're good at. And I think it helps us get patients in. And we talked a little bit about it the other day, but I don't know if you guys have any other comments about direct-to-patient kind of communication or other pathways into the center.
Well, I mean, if you think about how many patients are actually eligible, it's millions and millions, so we don't want too many referrals. But I think, if you're part of a system and you have a hypertension program, it's about educating your internists and then, your non-interventional cardiologists, nephrology, et cetera, because I mean, that's where we get all our referrals from, not just for the studies, but generally for the hypertension program. So I think if you build it, they'll come kind of thing. And then also, there is definitely that direct-to-consumer thing, at least for the trials. That's how we've got most of our patients is through social media, because if they were attracted to having a procedure as opposed to medication, and so that's how they came to us. So I think that there is a big component to that. I don't know, Michael. Do you want to add anything?
I agree very much with everything you said, and just quite frankly, just a plug for public health. I think if we are going to have a social media campaign, I'd love to have it, around poorly controlled high blood pressure rather than around a procedure, right? I mean, if patients really recognize the consequences that they were facing by not getting their blood pressure under control, maybe that they would be more likely to go ahead and seek out care, whether that be renal denervation or obviously starting much further back in the funnel and dealing with our frontline primary care docs and other providers.
Michael, I'm really glad you made that point. I mean, I think one of the benefits here, and we have to recognize that we're here at an interventional cardiology conference talking about this because there are some new devices that are investigational at the moment that are likely going to see the light of day very soon, right? And we want to integrate them appropriately into our clinical practice. But there's a really nice gain from that whole process. As you build hypertension centers at your institutions, everyone gains, right? It's not just the fraction of patients who might end up being candidates for renal denervation. It's all those poorly controlled patients who we now hopefully will get to go because we're taking a more organized approach. So I want to thank the panel. Talks were great. I learned a lot as always, and I want to thank the audience, and we'll see you soon. Where, I don't even know where that is. Hey, absolutely. Yes, absolutely. I've got to get to
Time, my friend.
Yeah, no, absolutely. Good, good. I'm glad. I've got to run to a thing, but Debbie, it was great seeing you. Are you going to do dinner?
I'll see you tonight. Will I see you tonight? Okay, I'll see you tonight. What's that? Oh, it is? Okay.
From here.
6:30?
Oh, you're in the Hyatt, right? You take that? Right in the Hyatt. Yeah, right in the Hyatt.
Oh, in the Hyatt. Okay, 6:30?